I'm Jess Pang. I'm the AphA Wales Deputy Branch Lead, and I'm just here to introduce the session. Just to have a note that if everyone can go on mute, so that we don't get any background noise. And the session is going to be recorded and be saved on the AphA Hub. We're just doing a little bit of tinkering with the slides for now, and then the the guest speakers will start their talk. Whilst we're waiting for that, just say the next Lunch and Learn is on the 11th of November. It's on Tableau. So it's Kickstart Tableau, connecting data, understanding the vocabulary, creating charts, and basically doing those basics of Tableau. So if you're interested in Tableau or just want to see what's out there, that's on the 11th of November with Charlotte Shearsby from Arden and Jen CSU. Now, okay, I'm going to introduce the session because it looks like the slides are there now. We're looking at bridging hearts, addressing inequalities in cardiovascular health. And I'll pass over. Is it Tom? Are you starting off, or are you just sharing the slides for now?
Oh yeah, I can kick off. Thanks for that. Yeah, hi everyone. Thanks very much for having us. My name's Tom. I'm the Health Analytics Lead at British Heart Foundation, and yeah, we've been invited here today to speak about a report that we published in the first half of the year called Bridging Hearts, which was a big combined analytics and policy report that we did looking at health inequalities relating to cardiovascular disease in the United Kingdom, with a focus on deprivation, sex and gender, and ethnicity. I am set. There we go. Slides have decided they will move. Cool. Yeah, so I'm joined today by two of my colleagues. So, and I'll let you guys introduce yourselves quickly. So, for my team as well, we've got Bruna.
Yeah, hi everybody. Thank you so much for having us. My name is Bruna Costa. I work with Tom in the health analytics team, but I'm qualitative insights lead, so kind of focusing more on words rather than numbers, and the kind of the patient experience.
Amy from our policy team.
Hi everyone. Yeah, I'm Amy. I'm the Senior Policy Officer at BHF, and I specialise in healthcare inequalities. So I work closely with Tom and Bruna, but separate teams.
I think we're going to do a brief kind of overview of kind of our respective functions at BHF and kind of how we came to look at health inequalities through these three particular lenses, just so that we're all kind of on the same page. And then we're broadly going to approach the kind of report as we do in the written version of the report, which is through those kind of three lenses that I mentioned earlier. So deprivation, sex and gender, and ethnicity. We'll kind of talk through each one by kind of like what the quantitative data shows, what we found in our kind of qualitative research, and then kind of the implications for our kind of policy and influencing activities. There will be time at the end for questions. So if you have any questions, feel free to drop them in the chat or just save them and pop your hand up at the end. We've run this through previously. I'll admit that it's probably about 5 or 6 months since we last talked through this, so you'll have to hold on if we're a little rusty at particular points, or I round the stats more than I would usually, perhaps when we kind of first started presenting all this. But I guess then, without any further ado, just some kind of, I forgot this was animated. I don't think I did the animations, so that could be a surprise. Yeah, just in terms of the kind of overall burden of cardiovascular disease, so the space in which kind of British Heart Foundation operates as a charity. Cardiovascular disease, which includes everything from heart attacks, coronary heart disease to strokes, is one of the main causes of kind of like non-communicable disease burden in the United Kingdom. Someone dies from a cardiovascular condition every 3 minutes. I'm not going to talk through every single stat on the slide because Roddy, who some of you may know, put a lot of stats on this one. But it is a disease that is growing in burden, in part due to the kind of growing and aging population of the United Kingdom. So, we've recently updated our estimated prevalence stats, so we believe that about over 8 million people across the UK are currently living with a cardiovascular condition. Millions more are living with a risk factors such as high blood pressure, raised cholesterol, diabetes, that put them at increased risk relative to the general population of developing a cardiovascular condition. And amongst under 75s, the progress since the onset of the pandemic in 2020 has basically been, well, there's been no progress. Our health indicators have been trending in the wrong direction. So we saw between 2020 and 2023 essentially kind of continual increases in the rate of premature mortality from cardiovascular disease amongst under 75s in the United Kingdom. And whilst, as of the most recent data, which dropped like last week or the week before, for under 75s, the rate has dropped a little, but we're still quite some way above the kind of pre-pandemic levels that we saw of cardiovascular mortality. So in a nutshell, it's a big disease area. It's broad. It affects a lot of people, both at the age of over 75 and under 75, and it is where BHF dedicates its resources. I'll hand it for Bruna for this one, I think.
I think that might be me, actually.
Or Amy.
Yeah. So yeah, just off the back of what Tom just introduced, you may or may not know the BHF is primarily a research charity, which means we dedicate a significant amount of funding to cardiovascular research in the UK every year, and we're actually the UK's largest independent funder of research into CVD. And in 2023 to 2024, we awarded around £112 million worth of research grants across the UK to better understand, prevent, and treat cardiovascular disease. The largest proportion of this funding went to research into heart failure and heart attacks. But as you can see from that graphic, we support a whole range of research into different cardiovascular and related conditions. Next slide, please. Thank you. And this is just a very sort of top line introduction to the Policy and Public Affairs team, which is the team that I sit on. We work really closely with Tom and Bruna to essentially turn their amazing stats and insights into policy calls on the UK government and national health systems to make life better, essentially, for people living with cardiovascular diseases. As I'm sure you know, the state of the NHS at the moment is really quite severe for cardiac patients. And in March of this year, the waiting list for cardiac care was double what it had been in 2021, standing at over 425,000. We've seen some slight improvements since the beginning of the year, but there's still over 400,000 people waiting for routine cardiac care on the NHS as of August. So we're facing a huge challenge. That picture sort of in the middle to the bottom was our response to this crisis, and it forms part of our wider Hearts Need More campaign last year. You might have seen at bus stops around the country, we had billboards with patients who are still waiting for routine cardiac care, and this was really just to highlight the scale of the challenge that we're facing. And all this work ladders up to our appearance at party conferences every year. So you can see in the bottom left and the top in the middle, that was our stand at this year's Labour Party conference. We were very happy that the Health Secretary, Wes Streeting, visited our stand, and we were able to highlight the ongoing cardiovascular crisis to him in person. And we will continue to do that through sort of written outputs and campaigns. So I think I'm handing over to Bruna now.
Thanks, Amy. Thanks, Tom. Yeah, so kind of that was Amy's introduction to the work that kind of policy do for BHF, and I'll just talk you through a little bit more on kind of mine and Tom's side, the Health Insights team, and how we fit into the broader picture. So while BHF are predominantly, as you know, a research funder, we do have an internal Health Insights team where myself and Tom work. We sit within the medical directorate, and so while we primarily kind of serve the medical directorate, we'll also kind of often work beyond across wider BHF. And within Health Insights, we've got various functions specifically for, which I'll briefly talk you through today, to provide kind of a breadth of insights and information to different stakeholders, if you like, internally, although we do provide external outputs, as for example, Bridging Hearts. So the first function within the Health Insights team that Tom leads is health analytics, and that's really about understanding CVD, the data, the numbers, the stats, the prevalence. I often feel that the health analytics team are kind of the truth keepers, and they kind of are able to control the information and the health stat information, how that's used. And as I say, that's the team that Tom leads. We've got a data science function, and so I would love to tell you in depth about what my colleagues in data science do, but I can only do the kind of top line. But they'll work with kind of complex code, kind of patient level data, but also population level, so kind of big data sets. And kind of also maximizing the use of cloud platforms for data storage and accessing different data sets too for BHF use. We have an impact evaluation side that's really about understanding the impact of the efforts of the medical directorate, both kind of research innovations, but also the projects that BHF fund as our primary function. And it's about understanding, so kind of doing insight projects to understand that impact, but also about communicating that impact. So putting together effective communications so that both BHF internally and externally people can understand what our funded work is doing and the impact it's having. And then finally, we have the qualitative functions. That's the function that I lead, and we'll work with different teams about providing that qualitative element to provide that nuance, that depth when we need it to expand our understanding. And CVD health inequalities is an example of where kind of utilizing that patient experience was really effective. Over to Tom now to tell you a bit more about health analytics.
Yeah, so Bruno's kind of done half my job for me there, really. But essentially, on our side of the team, we're a group of stats nerds, basically. So most of us, by kind of like academic training, are like epidemiologists or health statisticians, and we produce a range of outputs. Some of you may use some of them. We definitely get queries from people working kind of analytics roles throughout the health service across the 4 nations of the UK. We produce a lot of kind of bespoke analytical resources for a range of audiences. So some of those are very kind of academic or kind of like this. About as nerdy as you can think, people who'd want to read a kind of 100-page statistical compendium where we compile all the data on cardiovascular disease and its risk factors. And a big part of our job is putting the kind of analytics that we do on whether it's a population health topic or looking at something kind of like the current state of the cardiovascular workforce or elective waiting lists into kind of like language and terminology and formats that can be used by less statistically literate parts of the organization, including kind of like fundraising colleagues who might have very little kind of like clinical or kind of scientific background. And we also spend a lot of time advising internal and external audiences on how to fairly interpret statistical health information, or, for instance, how they should kind of formulate national targets for cardiovascular disease. I definitely spend a fair amount of time trying to talk down scare stories about statins from newspapers that I won't name, but some of us can probably think about the ones I'm alluding to. And then on Bruno's side of the team, just before we go into the kind of the report itself.
Yeah, thanks, Tom. And so, yeah, as Tom said, I kind of noted most of this, but just to give you a few concrete examples of what we do over an evaluation and impact, as I say, kind of using that mixed methods approach as appropriate. So on kind of impact evaluation, what we'll do is we'll design and carry out evaluation of health and care initiatives, but also kind of our research initiatives, and we'll develop effective narratives to communicate that. So I've got an example there about external outputs around our research successes, around protecting the brain, for example. We'll also put out narratives around our actual funding efforts. So there's a report there which is around the diversity of our research funding from 2020 to 2023. So kind of putting out those insights to ensure continuous improvement evaluation to ensure continuous improvement. On the insight side of things, we'll often design and carry out kind of end-to-end primary insight projects. An example of that is the heart-to-heart report, which is linked below. That is an internal piece. We've not reported that externally, but that acted as kind of a state of the nation mixed methods project with CVD patients, and we ensured kind of national representation too on our quant survey that we carried out to really hear from patients and get that information about, how they're doing, what care is looking like, and we've used some of that in Bridging Hearts. We'll support colleagues who will often do their own kind of insight projects for different needs, whether it be kind of fundraising, and they might not be extensive enough for us to do, but we'll support them to make sure that the methodology is robust enough for what they want to use it for. And then often we'll help interpret and apply the kind of insights, help our teams to figure out, well, what do we do with this information? What does that mean in practice? Over to Tom. Thanks, Tom.
Thanks, Bruno. So, Bridging Hearts, the title of the talk and the reason we're all here today. So we published a report in around springtime this year, looking at, as I said, health inequalities across the cardiovascular pathway through the lenses of deprivation, sex and gender, and ethnicity. This is the culmination of kind of like many years of work from our respective teams looking at health inequalities. But like in terms of a question of like why we did this, well, part of it it's important. CVD has long been understood to be intrinsically linked to the wider social determinants of health. We've known this from the mid 20th century from some major landmark cohort studies, such as the ones looking at kind of British civil servants, that basically found that lower social class was associated with a higher risk of dying from coronary heart disease. So we've known about the association between cardiovascular disease and these social determinants for a long time. And Amy might have to correct me on exactly when we launched our internal and external EDI strategy, but several years ago we launched an EDI strategy to bring EDI into everything that kind of BHF does, from our internal processes to the research we fund and to kind of what we seek to do in the kind of public sphere to, you know, advocate on behalf of everybody with cardiovascular disease or at risk from it in the UK. And under that, both our teams have an explicit kind of obligation to further the knowledge and evidence base about cardiovascular disease. It doesn't specify exactly in which areas, but it does specify that we should do it across the 4 nations of the UK. And we have sought to do it as kind of thoroughly as possible. And in its initial iteration, we have particularly focused on deprivation, sex and gender, and ethnicity. But it's also important kind of beyond an EDI lens, because if you take England, for example, where we have the 25% reduction target for premature cardiovascular mortality rates from the government, the only way that we're going to achieve such kind of like ambitious targets for the nation's overall cardiovascular health is to focus on those areas where the burden of cardiovascular disease is significantly larger than it is in the average person or group within the population. And I'll talk in some detail as we go through this about kind of where those areas are and why, just how kind of large those differences are. It's also, as I'll now hand briefly to Bruno to talk about, like a real kind of like first step for us in combining our quantitative and qualitative research functions. But Bruno's far more of a methodology nerd than I am, so I think this one's your wheelhouse, isn't it?
No, yeah, I think really briefly, potentially if you flash over to the next slide, Tom, it just about kind of, yeah, as Tom said, it was kind of the first time we did this, and but we found it to be very effective. But I'll let you kind of judge that, but kind of utilizing both approaches. So valuing, of course, we need those robust stats, we need those kind of strong numbers, but also there are gaps to kind of the knowledge, you know, our knowledge base currently, and kind of leaning on that patient experience and really spending time to understand that effectively was necessary. In addition to that, you'll see that, and I'll let Tom talk through the big kind of data sets that were used, but the qualitative engagement front. So we did the patient insight project that I mentioned earlier, which culminated in the Heart's Heart reports. That was both a kind of workshop, you know, focus group methodology and interviews, one-to-one, so providing patients with an opportunity. What we did there is actually over-recruit for currently underrepresented groups, so focusing again on the focus of bridging hearts, ethnic minorities, socioeconomically deprived individuals, and also ensuring an equal gender representation as well. We did some social media analyses, so thinking about and looking at the ways in which people are talking about health inequalities online, publicly visible spaces. We also carried out a really in-depth ethnography project where we went across the devolved nations across the UK and spoke to ethnic minority patients about their experiences of having cardiovascular disease or a risk factor. Tom, do you want to talk through the data sets we used?
Yeah, so we used a range of data sets from across the 4 nations, mainly from the ONS and the equivalent devolved statistical equivalent official statistical agencies in devolved nations. That's a mouthful. We also drew on a lot of data collated by OHID, particularly that from the Fingertips tool, along with CVD Prevent Health Survey for England, and we also undertook a perhaps not fully systematic, but a highly structured review of the kind of grey and academic literature, which is particularly important when looking at those areas like ethnicity, where I think many of us on this call will be aware of the kind of like limits, particularly those highlighted by the pandemic, about the collection, reporting and utilization of ethnicity related healthcare measures in the UK. And we have somewhat sought to fill that gap using the academic literature. But in terms of kind of headline findings, we're going to go kind of like lens by lens here. When we looked at deprivation, The headline findings are incredibly depressing. Essentially, if you live in a more deprived area of the UK, and the graph on the right is just for England because of the way that IMD is reported, you're more likely to be at risk of and to die, particularly to die prematurely from a cardiovascular condition. And this is true of coronary heart disease and stroke, as well as looking at the cardiovascular disease kind of category as a whole. In fact, if you live in the 10% most deprived parts of England, you're more than twice as likely to die before the age of 75 from a cardiovascular condition. And whilst directly equivalent data is not necessarily available for all the nations, we find this finding when you look at, say, local authorities in every single one of the devolved nations. So there is a very clear, consistently observed association between premature rates of mortality from CVD and socioeconomic deprivation. More animations. I'm just going to, yeah, but we've also find evidence of these inequalities across the entire cardiac pathway, right from people's risk of developing CVD in the first place, as I said, all the way up, unfortunately, to death. The association is there for almost every major clinical, environmental, and lifestyle-related risk factor for cardiovascular disease. Most prominent are hypertension, so high blood pressure, smoking, obesity, diabetes, poor diet, and low physical activity. The only one really missing from there is cholesterol, where if you live in a more deprived area, the relationship is kind of intersected by gender. But if you're interested in that level of detail, I would suggest you go and read the report in full. Unfortunately, people living in more deprived areas also, from data, seem to have reduced access to primary care and poorer management of some clinical risk factors for cardiovascular disease. So that's not across the board, but there are some of the major ones where the management is worse amongst more deprived parts of the country. People in more deprived areas also tend to access care in a worse state of health. So, for instance, they are overrepresented in A&E admissions for cardiovascular disease relative to elective surgery. And they are also less likely to access and finish cardiac rehabilitation. And when people do have cardiac surgery, outcomes are worse for people from more deprived areas. So it's quite a very depressing picture. But on the qualitative side, Bruce.
Yeah, so the qualitative data on kind of deprivation is the one where kind of we have the least shocking information. We understand how deprivation impacts people's access to and experiences of health, but just some quotes here to highlight. So we had a lot of people talk to us about how the disparities, geographical kind of disparities, manifest in their day-to-day. So just a quote there. My sister, her GP gave her a free monitor, blood pressure. No, I had to buy my own. And then another one, people actually conducting significant life changes to survive these inequities geographically. So a quote, I refused to go to hospital in London. I moved to Essex. The care I'm getting is very different in Essex. It's taken more seriously, more face-to-face services, more time given. The cardiologist is in organising events in London. I'm lucky if I see anyone at all. So that quite stark, kind of seeing how that manifests day to day in people's lives, and you see the people that do have resource to kind of go elsewhere and also seek private care, and those that don't and kind of have to stay in that circumstance. And then also the accessibility of health and kind of the barriers that people face, time, money, the places that they live and whether there's actually access to safe outdoor spaces to carry out exercise. So again, a quote there, olive oil, oily fish and salmon, they're all really expensive. 5 years ago, we used to eat salmon, but we don't now. Who can afford olive oil? It's becoming impossible. We can't afford to eat heart-healthy stuff as they're expensive. Another one, they say exercise more, but they don't look at the barriers to exercise. My auntie who has diabetes gets swimming sessions for free, but in my area, you just get linked to a website. Over to Amy to talk on the policy side.
Thanks, Bruna. Yeah, so I'm just going to round off this section with a brief sort of walkthrough of our policy calls as part of the deprivation chapter of Bridging Hearts. There's a lot more detail, obviously, in the actual report, so this is just a whistle-stop tour of each recommendation. These are the policies that we know will have the greatest impact on tackling cardiovascular inequalities related to deprivation, and they are all population-based measures that are largely focused on improving the healthfulness of the environment that people live in, not putting the onus on individuals to sort of manage their own health, because we know that people's health is largely sort of directed by their wider environment. So the first recommendation there is for government to invest more in prevention and public health. We know that the public health grant, which has historically funded the majority of local public health services in England, at least, and that includes things like stop smoking services and weight management services, has been cut by a quarter since 2016. And this has had a really notable impact on the provision of public health services, especially in more deprived areas. We're also calling on government to take a cross-government approach to tackling inequalities. Bridging Hearts called for a renewed inequalities strategy. We've actually broadened that out a little bit since the report was published, to essentially just call for government to take a cross-government approach. We know that health inequalities really requires action from the whole of government that goes beyond just the Department of Health and Social Care, but departments like education, the Ministry for Housing, even sort of media. All government departments really need to work together to tackle a challenge of this scale. And finally, we're really calling on government to make the polluter pay when it comes to CVD inequalities. So this looks like placing industry levies on the tobacco industry and less healthy food producers, and to use those additional funds to support local initiatives to widen access to healthy food, stop smoking support, things like this. So yeah, that's a very whistle-stop tour of our recommendations, but do read the report for more detail on each of them. And I'm handing back to Tom.
Yeah, sorry, you saw me just kind of dashing through the slides there because for data protection reasons, we had to at the last minute remove the pictures that we'd included from some of the focus groups we conducted because we actually didn't get permissions to use them in this kind of setting. So, you know, we take data protection very seriously at BHF. But yeah, so chapter 2 looked at sex and gender, and the evidence for kind of how cardiovascular health is impacted by sex and gender is a bit more nuanced than deprivation. It's not just a case of, you know, things are bad for one sex, they're great for the other sex or gender. It's a lot more complicated. But in a kind of nutshell, men die at much higher rates from cardiovascular disease, particularly at younger ages, particularly under the age of 75. And our review of the literature found that was largely due to a mixture of both biological and behavioural reasons. But on the other side of things, the evidence is quite clear that, particularly in England and Wales, where there's better academic studies, that when women are at risk of developing cardiovascular disease, or when they have been diagnosed with cardiovascular disease, or they're trying to get a diagnosis for a condition of a cardiovascular condition they do have, evidence shows that they're significantly more likely to be misdiagnosed, diagnosed late, or receive poorer treatment. And when we dive into a bit more detail, when we look at men's cardiovascular risk, the risk of men dying from CVD at greater rates than women, again, particularly under the age of 75, is driven by a number of factors. So on the kind of physiological side of it, estrogen appears to have a protective effect against cardiovascular disease, and that the evidence on that is quite clear. And men are also more likely to store their fat as visceral fat, which increases the risk of cardiovascular disease more than storing your body fat elsewhere. Men are also more likely to engage in greater numbers in smoking and failing to meet kind of standard dietary requirements, particularly around kind of lower intake of saturated fat and higher intake of dietary fiber. So by both kind of physiological and kind of more like psychosocial behavioral reasons, men have a higher cardiovascular risk. There is also some limited evidence, but something that we would really kind of encourage researchers to look at more seriously, about men not engaging in primary care and particularly kind of preventive care. So there is some evidence that men are less likely to go to the GP, which is really problematic from a cardiovascular perspective, because about 80% of the burden of both morbidity and mortality from cardiovascular disease is attributable to modifiable risk factors, and that includes things like hypertension and high cholesterol that are manageable in a clinical setting. So men's lack of engagement in those areas, we would hypothesize, but hasn't been clearly linked to be kind of hindering men's cardiovascular outcomes. There's also with men a particularly strong intersection between sex and gender and deprivation and geography. So the absolute differences between men and women's outcomes are much larger in more deprived areas, and there's a particularly big difference in the rate of premature cardiovascular mortality between men living in the north and the south, some but not all of which is explained by deprivation. However, again, on the other side of things, women face inequalities across the whole cardiovascular pathway. When we look at cardiovascular risk factors, for instance, whilst less women smoke, women's risk of cardiovascular disease from smoking is actually higher, i.e. so if you're a woman and you smoke, your risk of cardiovascular disease is higher than if you're a man and you smoke. And they also experience some sex-specific risk factors, in some ways the most notable of which is menopause. After menopause, the differences in cardiovascular health between men and women narrow, in part due to the effect of kind of different estrogen levels. And then when we look to kind of like women who do have cardiovascular disease and are trying to get a diagnosis, there are delays, higher rates of misdiagnosis, and evidence that when they are diagnosed, they're not treated as well to clinical guidelines. And one study that we've kind of pulled out in the top right, which was conducted in England and Wales on hospital data, I think it was mid-2010s, going back to about 2006, found that women were 50% more likely to receive an initial wrong diagnosis for heart attack, which has a really poor impact on the subsequent outcomes. And then finally, women are kind of like, well, we would say famously within BHF, because we're always going on about it, but I think it's perhaps not sufficiently understood at a popular kind of level that women are underrepresented, not just in kind of like medical and clinical research overall, but also particularly within cardiovascular disease. And if women aren't included in trials, then it has upstream effects in terms of the effectiveness of treatments for cardiovascular disease in women. All of which, the slide of this nutshell is in a sense almost that patriarchy hurts everybody, but in different ways, both men and women are at higher risk of cardiovascular disease in a way that should be thought of in strategies to tackle poor cardiovascular outcomes in both. On the qualitative side, Bruna.
Yeah, thanks, Tom. Thanks. That was, I think, a really good job of describing some quite complicated data. The qualitative data helped us kind of look at the experiences of women, predominantly of what that looks like day to day, of what Tom mentioned, those inequalities playing out from across the kind of CVD pathway. I suppose even before, you know, the actual research, CVD research, the knowledge that care is based on. So we see how those inequalities play out for women. Women kind of reporting, you know, low understanding of specific risks, CVD risks. Symptoms, the manifestation of symptoms, kind of what does a heart attack look like for a woman? Could that be different? Are health providers kind of trained to respond to that? Women telling us that the information is often unavailable, not accessible, and that generally they're not feeling that their care needs are being met as women. And this seemed to be particularly prevalent when kind of sex-specific differences became difficult to ignore, such as, for example, post-menopause, as kind of Tom mentioned, and that, you know, becoming so apparent, but women having that real difficulty with their health providers in receiving the care they feel they need. So just a quote there, if a man was going to find or seek out that information, he'd find it quite readily. But if a woman was to find that information, she'd have to specifically seek out those symptoms on women. A really interesting aspect of our sex and gender qualitative data was kind of looking into that aspect of intersectionality. So intersectionality is something that we argue for very strongly within Bridging Hearts, and I think kind of that makes sense as we go through this PowerPoint, but arguing that, you know, to understand inequalities and to understand risk, you must look at the different elements of a person's identity. So whilst being a woman is one aspect of identity, we also found those specific additional kind of challenges for ethnic minority women. So they're about potentially kind of higher risk of different conditions. A quote there, the evidence is there. I retired from midwifery 3 years ago, and Black women had a higher chance of preeclampsia, and Asian ladies had a higher chance of gestational diabetes. It's something that's known, and therefore special care is needed, but is it given? And then another one there, kind of again, the experience of ethnic minority women and how receiving a diagnosis of CVD for them was especially challenging, again, pulling in that ethnicity element too, and leading to kind of shame and difficult feelings around the diagnosis. So a quote there, I think there was definitely some small bit of me that kind of needed to navigate and get over that shame after the initial diagnosis, you know, of becoming another statistic of an Asian young woman who's also got high cholesterol and is predisposed to high blood pressure. So over to, oh, we've got a few more quotes, wow. I'm known to put in extra quotes. So again, kind of what that manifested like in healthcare. So reports of that kind of stigma, bias, also bias around other aspects, which also seem to be linked to gender, such as body size. So kind of feeling like, you know, if they lived in a larger body, if they have higher body weight, kind of health professionals putting that kind of judgment on them, and not looking beyond that, and not seeking to kind of support them more inclusively. And then social roles. So for women, of course, so thinking about many responsibilities of women in society, different cultural backgrounds and different religions to kind of having higher requirements for women, and that feeling, and women feeling like that makes it more difficult for them to access effective care. So just one quote on that. The other thing is childcare. Some appointments I can't go with childcare. When they give me a day that I have children, I have to ask for another appointment. But sometimes that can be 2 weeks later. It really affects me. Over to Amy. Thank you.
Thanks, Bruna. So yeah, again, I'm just going to round off this section with our policy recommendations from the sex chapter. So just briefly, that first recommendation, improve men's engagement with primary care. As Tom and Bruna both highlighted, we know that men have high prevalence of cardiovascular risk factors, and are also kind of less likely to approach primary care and preventative services. This includes seeing their GP or accessing services like the NHS Health Check. So Bridging Hearts proposed a couple of possible solutions to this problem, one of which is meeting men where they are. So there's a lot of brilliant sort of local pilots out there, getting blood pressure checks into local barbershops and football clubs, things like that. We think pilots like that are successful. What we really want government to do is to expand these to a national scale and input some proper evaluation so that we can really see what impact they're having. Related to this, we did submit some evidence to the government's call for evidence to inform the men's health strategy for England, which is forthcoming, where we go into a bit more detail around these pilots and other sort of possible solutions for increasing men's engagement with healthcare services. So be really happy to share that submission with anyone that's interested. Recommendation 2, 3, and 4, actually, on a positive note, are things that government have taken some steps towards just last week. You might have seen in the news that government announced they're going to be including information about the menopause in the NHS Health Check for the first time. As Tom highlighted, we know that going through the menopause and the impact that that has on lowering estrogen levels has a significant impact on cardiovascular risk for women. So we're really happy to see that. And government have also announced that they're going to be renewing the women's health strategy for England. So we'll be looking to that to influence and get some of our policy calls in there as well. And then finally, improving representation of women in cardiovascular research. We know that the only way to really understand these barriers to diagnosis and care that women are facing is to increase the proportion of women that are represented both as researchers and research participants in clinical research. So yeah, we're doing a lot across the organisation on our sort of research side to increase women's representation there too. Handing back to Tom, I believe.
I think just for Amy and Bruno, I think we should try and finish at 10 to in terms of speech so that we can leave 10 minutes for questions. We hadn't practiced run through this in a while. Okay, so last chapter, and annoyingly, in some ways, given that the time constraints now, the most difficult one the one that was most difficult for us to conduct and communicate in a few bullet points is ethnicity. The headline finding of ethnicity is essentially that the relationship between ethnicity and cardiovascular disease is very nuanced, and population level data is limited in this area, particularly from the kind of data sets that we would use to look at other lenses like deprivation and sex. Many of the reasons for those are known and were highlighted during the pandemic, and it includes the way that data on ethnicity is kind of recorded and then utilised in major healthcare data sets. In overall summary is that it's very clear that the risk of developing cardiovascular disease is higher for South Asian groups compared to white groups, and that seems to be the case even after you account for a range of confounding variables. But the picture is much less clear for Black populations in the UK, and I will get to that. Some of the reasons are put down to issues such as racism, communication barriers, and lack of culturally competent information, and these can contribute to poor healthcare experiences. But yeah, I'm going to, in the name of avoiding this over summarizing, I'm going to go into the nitty-gritty detail because there's a lot of data nerds here I think will be quite interested in this. So the quantitative evidence for inequalities between ethnic groups in the UK is highly nuanced. There is a lot that we can learn from it. So the current state of the evidence isn't necessarily a call for, like, it should be. It's not a reason for inaction or just to kind of not challenge the status quo. The amount of data available is getting better, but that's only because groups and individuals have continued to call for it to be addressed. For instance, there have been some really ambitious efforts from the ONS to address the lack of kind of ethnic specific mortality data using linked data, but the results of anything have just flagged just how highly nuanced this is. The other thing that is a barrier when using population level data, particularly from kind of things like ONS, is that deprivation is recognised, particularly in the academic literature, as a really confounding factor in the association between deprivation and cardiovascular disease. It's particularly the case for Black populations who are massively overrepresented in the 10 to 20% most deprived parts of the UK. And you can't pick out the nuance of that relationship unless you run a kind of regression model. So subsequently for this, you really do need to look at both the population level data to assess kind of the scale of the burden, but then to understand the reasons why you really do need to look at the academic literature. And it's also really important to recognize that there's huge variation between the kind of large ethnic groups that tend to be reported on in the major data sets, so kind of like generally white, Asian, Black, because there's significant variation within those groups. That even some big academic studies like those based on biobank are often not sufficiently statistically powered to identify the differences. And in terms of what we found when we looked at these, so to some extent, bearing all those kind of like methodological limitations in mind, the literature is very clear that there is a significantly higher risk of developing CVD amongst people with South Asian backgrounds in the UK compared to white groups. That is the case both in the big national exercises conducted by ONS that found that association at a population level, but also by the academic literature when they've done multi-regression analysis to kind of tease out the effect of confounders. It is possible that it's just down to an unidentified confounder yet, but there is a very clear, consistent finding in the literature. When it comes to Black populations, the association is a lot more nuanced. So, for instance, clinical risk factors for cardiovascular disease, particularly hypertension and diabetes, are significantly more prevalent in both Black and South Asian groups in the UK than in white populations, as is obesity. And in obesity, that is recognised in the NICE guidelines for obesity, where the threshold for Black, African and Caribbean groups and for some South Asian groups, the risk of cardiovascular disease is higher at lower BMI thresholds than in white European populations, and subsequently the clinical guidance does reflect that. But we also find that, kind of looking beyond that, that there are issues in access. So the academic literature is quite clear that people from Black backgrounds experience reduced access to primary care, which, as I said, in the context of men's cardiovascular health is really important because 80% of the burden of CVD is attributable to modifiable risk factors that can be managed in primary care. But also that Black groups experienced a reduced access to cardiac surgery and had higher adverse outcomes from cardiac surgery, which is obviously not acceptable. On the qualitative side, Bruna.
Yeah, so I won't read the quotes. Although, as Tom said, ethnicity is where kind of that nuance is really needed. So I'll be happy to speak to anybody after this on the qual data. But just some of the stuff that kind of came out and helped us to potentially contextualize why those inequalities are showing up, especially where the kind of biophysical relationship is unclear. So people speaking to us about their perceived impact of prolonged discrimination and continuous experiences of discrimination, and the kind of the stress that causes for them in society, and the health impacts that they feel that they have. The impact of cultural differences around navigating healthcare. So potential cultural differences in how acceptable it is to talk about health, health needs, potentially around kind of well-being, differences in health behaviors, so what people eat and people recognizing how that impacts their health and their day-to-day, but also reporting challenges in addressing that and lack of support. The really interesting finding for me is around how people discuss the aspect that Tom just kind of mentioned around the possible increased risk and the relationship with ethnicity and what that looks like. Again, the data is unclear and difficult for us to understand ourselves. So for patients, how that plays out is that just becomes another barrier to accessing care, to being able to feel like they can trust the care that they're receiving, having health professionals who talk about that potential differences, having health professionals who don't acknowledge that. And that just breeds more kind of mistrust, creates division. Next slide, please. Thank you. Again, that even impacting how patients feel around differences in what they should be prescribed, in the kind of treatment route that they should take, not being so likely to follow the prescribed recommendations from health professionals if they don't have that trust. Ethnic minority patients also talking to us a lot about negative experiences with health professionals over experiences of bias and racism, but also more covert kind of daily challenges, kind of reporting reduced access to care and interest in seeking care or following medical advice because of previous and ongoing challenges. And then too, that kind of cultural appropriateness of care and the barriers that are posed by language, the cultural context, and lots of people kind of speaking to us about the importance of community care and community support, and how, especially since COVID, as that's being further and further reduced, that's further exacerbating inequalities as they perceive them. Quickly over to Amy. Sorry, Amy, not left you much time.
No, that's all right. Thanks, Bruna. Yes, so just very quickly, policy recommendations on the ethnicity chapter. That first one is prevention with proportionate universalism approach, which is a mouthful, but essentially that's just talking to healthcare services prioritizing the communities that need their care more. So still maintaining sort of a standard of care across all communities, but prioritizing the communities that need more targeted approaches, better, more consistent data collection. As we've said kind of throughout this presentation, we can't tackle inequalities without properly understanding them. So we know that there are differences and inequities in how ethnicity data is collected across the UK. So we're calling for more consistency around that. And the report gives some examples on how that can be achieved. Ensuring that all services, information and support is culturally sensitive and accessible to all. This seems like quite an obvious one, but actually, you know, as Bruna highlighted, there are a lot of communication barriers and cultural barriers to people accessing the care that they really need. So again, kind of more detail in the report on the kind of things that we want to see there. And then just as ever, improving representation of ethnic minorities in clinical research. Again, we're not going to be able to tackle these really kind of systemic barriers to diagnosis, care, prevention without representative clinical research. I think there's one more slide just on next steps, very briefly. So just building off Bridging Hearts, which came out in April, we're going into a bit more detail around some of the specific areas. One of those we actually haven't talked through today, but there's a small section in the report on the association between serious mental illness and CVD. We're taking a particular kind of look into that and seeing kind of opportunities there to do some policy development and influencing. Also around the ethnicity chapter, as we mentioned, that's one of the more nuanced areas. So we're looking at that in a bit more detail as well. AphA members are invited to apply our methods. That's sort of referring to the mixed methodology approach that we took in this report and to better understand CVD inequalities in the populations that you each serve. We're actively influencing the men's health strategy for England. We'll be looking to the newly announced women's health strategy too to influence that, make sure that these policy calls get in there. And we'll continue to work with health systems and bringing our analytical expertise to highlight underlying inequalities. And I'm not sure, Tom, if you wanted to briefly touch on, we've got a couple analytical bits in the pipeline.
Yeah, we're doing a couple of pieces at the moment, or in the very early days, looking at the kind of geographic differences in CVD, so those that might not be attributable to the kind of inequalities outlined today. So we're doing a piece looking at the cardiovascular health of coastal communities at the moment, and then next year we're going to be looking at rural and urban differences in cardiovascular health. So covering even more inequalities basis, basically. I think just as last, if you find this talk interesting, the link to the full report is on the BHF website. We also have a large range of cardiovascular statistics that you can use and access at any point, and we have a range of other reports, such as the one I've highlighted here, looking at different lenses of socioeconomic inequalities. So yeah, we've got lots of stuff out there, and if you ever have any questions about CVD, please do just get in touch. But yeah, that's it for now. So I'll just kind of like go back to a generic red screen so that we can have some questions if there are any.
Thank you, Tom, Bruna and Amy. That was really interesting talk. Are there any questions? I've got a couple, but I'll give a chance for others to put their hands up, put it in chat. I'm going to jump in then. I was just wondering, so there were some kind of very powerful quotes in your slides there. I was just wondering how you choose what you think is going to be the most effective qualitative statements to include.
Yeah, no, good point. So we did a quality. We can kind of, don't know that we have time today, but I'd be happy to share more on kind of the method that we took to do a kind of full qualitative analyses and ensuring that kind of yeah, we're not cherry picking what fits, right? But that's an interesting question around how you kind of merge both quant data and qual findings. We had a positive experience on this project that in the ways in which we analyzed the data, the themes that we reported from those data aligned, and where they didn't align, shed light on the quant findings, if you like. So we did an independent analysis of the data and had our findings, and then we were able to pick, for the purpose of this presentation, the quotes that we felt demonstrate that analytical statement. But there was a full analysis done on the data prior to that. Yeah, hope that answers the question.
And I'm kind of looking to see if anyone else has got.
Oh, is Jessica frozen or anything
Kind
else?
of.
Yes, I think she has.
Yeah,
Okay.
she's gone for me.
Am I
Oh,
back?
yeah. You seem
You're
to be
back.
back.
Maybe.
Gone
Sure.
again.
Problems. Hello?
Hello.
Oh, did it?
We can hear you.
Cool. I think we're having technical difficulties. So any other questions at all, just while Jessica
I
gets
feel
there?
like I'm. This is a struggle at the end. Sorry, everyone.
That's all right.
Let's see. Okay. Yes, I might type some stuff in a minute.
You actually do seem
I
to be
guess.
speaking clearly now, just as a heads up.
Okay. Well, I guess one question was, there's a few different teams that you broke down, but you've all worked together on this. I wondered if you had any reflections on how you organised that and how that works for your organisation.
Oh, that's a good
Great
question.
question.
I think there are some of us who individually work together, like historically have worked together quite a lot. So I think particularly like our quantitative kind of like health analytics function and policy have worked together for years because we predate, I guess, chronologically the establishment of a qual team. So I think our ways of working have always been quite established. But I think over the years there were definitely some teething issues in terms of like where do you draw the line between what is policy and what is kind of analytics. But I think it just trying to make very clear that analytics is kind of there to support like quality of evidence, both in terms of it being like kind of like deep, rich, useful insight for people to use, but also that, and this is the purpose that we serve the wider organization, kind of like bulletproof. So, we will go through and read all the sources and quality check the data and just help, I think, and I'm not going to speak for Amy, but like ensuring that basically everything that we do is kind of evidence driven and that people can have, like, we can be an empowering function to let people do their jobs with more confidence. Yeah, I don't know. Has anyone else got any thoughts on that one?
Just to add, I suppose, sorry, I'll add my bit, I guess, on the qual. So it's an interesting question. It got me thinking around maybe we take for granted that I think we work quite effectively together, but I think what makes it particularly effective, our working together, is that we can provide, as I said earlier, that kind of analytical oversight, I suppose, and we'll support our colleagues then to feel confident that how they're applying those insights, they'll feel confident in applying those insights, knowing that the insights are robust so that then they can feel confident in their own work. And in terms of qualitative insights, that's been the same, speaking to colleagues about the difference between carrying out a full qualitative scale project that is robust in all aspects versus speaking to some patients that are already signed up, for example, to some type of patient feedback pathway. So kind of being able to kind of retrospectively go back and then collaborate that way. Amy, how did it look on the policy side? Yeah, sorry, Tom.
Maybe go ahead with it.
No, you go, Tom. I was just going to say, yeah, basically everything that you guys said. We work in a very natural way, I think.
Yeah, I would say almost. Sorry.
Yeah, no, go for it.
I was going to say, I think almost the biggest challenge that we had in terms of ways of working was with more senior stakeholders. So I think one of the ways that we were really effective was that basically the people doing the work were very much aligned and spent a lot of time discussing the subject matter and so that we all understood the areas where it was taking us longer to come to like more definite conclusions and like kind of like to really kind of like synthesize, particularly in the kind of for the ethnicity chapter, like what the state of the evidence was. And that was really useful in the face of pressures from kind of more senior stakeholders involved in, say, with like the EDI strategy, and including, I think, at points, quite senior leadership at BHF who wanted to go out and talk about this and wanted to know why it was taking so long, because they weren't used to dealing with such nuance in the findings. They were, because the BHF has always been going on about how bad things are from a deprivation perspective. For instance, I think some senior stakeholders expected it to be that clear, i.e. it would be bad for every ethnic minority group because of general kind of expectations about the way in which patriarchy disadvantages women, that it would be consistently women who were disadvantaged. And I think we had to kind of create a united front and I think talk our respective kind of senior like stakeholders through like why we needed to talk with nuance, why nuance was important, and why nuance would help us kind of ultimately like lead to better kind of influencing and kind of like financial decisions off the back of this. I think there is one question in the chat. Yeah,
there is one question in the chat. Do you have time to answer this one? Yeah. So it says, how does the BHF address the challenge of integrating data from diverse clinical, genomic and lifestyle sources to bring a coherent picture of cardiovascular risk across populations?
That's a really good question. I think as almost like a bit of a cop-out answer. To some degree, we don't have to formulate this is the exact coherent picture. This is what we should think people should do clinically off the back of it. And essentially what we were really trying to do is just kind of provide as much evidence as possible so that people looking at kind of like clinical decision-making criteria or choosing where to spend kind of like money within the health service would be best focusing their efforts. So just basically highlighting areas where inequities or inequalities were most apparent, and trying to communicate through the report the ways in which it is impossible to kind of get an overall picture, because whilst there might be differences at a group level, there are even more differences at an individual level. I think as you potentially kind of refer to there with the genomic factors, like we're never going to be able to give a kind of definite answer as to like which exact populations are the combinations of deprivation, ethnicity, and like sex and gender, and many other factors such as geography and kind of like, for instance, serious mental illness that we've not described, to kind of provide any sort of kind of like ranking. But I think our focus throughout was bringing together the kind of best quality data sources for each of those areas and highlighting what we did know most confidently, and also highlighting where we didn't think there was sufficient information for people to make decisions off the back of what we found. For instance, there are many questions I think remaining about the independent risk of having Black ethnicity versus having white ethnicity in the UK when you account for differences in things like deprivation, and different burden of risk factors that I don't think there is enough confidence to make clinical decisions on outside of the specific risk factors. Sorry, that was a very rambly answer for a question that basically asked about coherence. I don't know if anyone else has any thoughts.
No, other than I guess our internal insight work, as I mentioned, we did a project last year which was heart to heart. That was a state of the nation picture. Again, as Tom said, it's impossible. But what we did do is carried out a YouGov survey, which we developed quite a robust sampling framework to ensure representation of CVD and risk factor patients across the UK, considering things like deprivation, ethnicity, geographic kind of spread, other things, income, education, lots and lots of things. So the list is endless, and we've done efforts towards doing that, but it's never perfect. But we can share more information about those methodologies if helpful.
Oh, there's a follow-up question here. about how you're ensuring that algorithmic approaches remain transparent and equitable across different patient groups and contexts.
I don't think we've really done anything in particular detail on this. That we have, obviously, whenever there's comment, we have at points looked at AI, for instance, which I think is where obviously most of the algorithmic models come into, and we have stressed in the past the kind of whenever we are asked publicly to comment on it or are asked for advice, kind of behind the scenes situations, which is that the quality of your output is only as good as the data that you put in, and we would stress and highlight the examples of where poor data or like just data that's not quite good enough could lead algorithms trained on those data to make decisions that they might not come to if they had a fully representative data source set. For instance, there are definite problems with some of the academic literature that look at biobank data and being able to identify statistically significant differences that might actually exist due to the small sample size of certain ethnic groups within them. So I think we would just be highlighting what lots of other organizations in the space are doing, which is that you need representative data if you're going to produce tools that are in any way automating or like decision making or kind of advice to people who are in decision making areas, and that if that requires, I think there are, and I think there's lots of progress in that. So for instance, if you look at organizations like Our Future Health, there are people out there trying to create better data sets that are more representative, but I think we just have to kind of shout about it whenever asked and stress that it's important and highlight through all the things that we've seen why it's important to look at these individual areas and to look at them together, and highlight also where clinical practice already reflects this, such as different BMI thresholds for receiving treatments for high body mass index based on, for instance, on ethnic grounds. So just basically in summary saying that it's important and telling people that it is, and just taking a critical eye to what the actual data inputs are when studies come out that are talking about kind of algorithmic approaches.
Thank you very much. I think we've overrun a bit there, so I think I'll close it now. Hopefully you'll be able to get in touch, Matthew, if you have any extra questions. I can see you typing. That's the only reason I say that. So just let us know. But I'll close it there. Thank you very much for coming along from the British Heart Foundation. That was really interesting. So thank you. And just to note that there's another Lunch and Learn on the 11th of November around Tableau. So hope to see more of you there again. Thank you very much.
Thank you.
Thanks for having us.